Sir, we are live now. With all your permission, I'm starting this session.
Please do.
Good afternoon, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, none other than Dr. Rajesh Jindal, sir. Sir has done MBBS, MD in Radiotherapy, and consultant at Medela Cancer Care Center, Agarpara. Today, sir is going to discuss on a topic, HPV and cervical cancer. Let me tell you overview of the topic. HPV is a common sexually transmitted infection, is strongly linked to the development of cervical cancer. Cervical cancer, primarily caused by persistent HPV infection, is a significant global health concern among women. Regular screening of HPV vaccination are critical strategies for preventing and detecting cervical cancer at any stage, improving outcome for women. To know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed.
Thank you very much. আমি আপনার সবাইকে নমস্কার জানাতে চাই, and I am Dr. Rajesh Jindal from Calcutta. My hospital is Medela Cancer Care Center. We recently arranged into a tie-up with another entity called Carcinos, but that can come later and that can be withheld as of now. So I would come to the point straight off. This is, how does this thing move? Okay, yeah. So this is what my hospital looks like. This is an old photograph when we still used to give COVID vaccination. Now, my talk would be split mainly in three sections, smoothly merging into each other, of course. The first 8 to 9 slides would be about the virus itself. Then comes CA cervix, about the symptomatology, etc. And then comes the HPV, its role in the clinic, and how can we make use of the knowledge which we've gained about the virus. So HPV, well, papilloma viruses are a member of the Papoviridae family, which also includes 2 other viruses, which is polyoma virus and a vacuolating virus. It is a relatively small non-enveloped virus. Now, non-enveloped means that does not have an outer lipid coat. It is small, 55 nanometers in diameter, resembles a golf ball, and it consists of a single strand of double-stranded DNA molecule, which is circular in shape. And you can see on the right side, this is what it looks like, hence the resemblance to a golf ball. Now, papilloma viruses are ubiquitous, they are widespread, and they're also specific for the respective host. जो ह्यूमन वायरस है वो ह्यूमन को अफेक्ट करेगा, और जो एनिमल वायरस है वो एनिमल को अफेक्ट करेगा. They can be subdivided into low risk and high risk types. The low risk being 6, 11, 42, 43, and so forth. High risk viruses are numerous, 16, 18, the most prominent of them, 31, 33, and so on and so forth, going right up to 70. And intermediate risk viruses, not so common, and they are not found in the malignancy also. They are found in squamous intraepithelial inclusion lesions kind of things. So they are not very much, they have not garnered so much of attention from the virologists or the clinicians. Now, HPV conditions range from innocuous, harmless lesions up to frank malignancies. However, most of the HPV lesions are benign, infections are benign. It was in the early 1980s that Dr. Harald Zorhausen from Germany, he linked the genital HPV to cancer cervix, and this work was so groundbreaking and so phenomenal that he won the Nobel Prize for this thing. The magnitude of association between HPV and cervical squamous cell carcinoma is even higher than that for the association between smoking and lung cancer. So 99.7% of all the squamous cell carcinomas of the cervix have an HPV etiology behind them. So that is the strength of the association between HPV and the cervical squamous cell carcinoma. And HPV spreads through the sexual contact, infects primarily the genitalia and the anal opening in both men as well as women. The common types, like as I said, HPV accounts for almost 100%, which is 99.7% of squamous cell carcinomas of the cervix. Type 16 is responsible for half of them, and the other 25 to 30% is accounted by types 18, 31, and 45. Adenocarcinoma is less dependent on its etiology for the HPV virus. However, less than 40 years of age, 89% of adeno-CAs of the cervix are associated with HPV, but it falls to 43% if the woman has an adeno-CA of the cervix and she is beyond the age of 60. Now, we all know what is the cervix and where is the cervix. It is the lower part of the womb, also known as a uterine cervix, connects the body of the uterus to the vagina, which is the birth canal, of course, and the length of the cervix is approximately 2.5 centimeters. It is a thick muscular organ. Well, the magnitude of the problem will help put this thing into perspective as to why we are talking of this problem and not any other problem. Well, it is the most common malignancy in the rural areas, in the badlands of Bihar, Orissa, MP, Rajasthan, Maharashtra, Andhra, you name the state, and in the rural areas, it is a significant health issue. The incidence ranges from 5.6 to 24.3 cases per 1 lakh women. The incidence in Kolkata is roughly 12 cases per 100,000 women. The age range affected is generally between the age of 55 to 59 years. So this is the disease burden that you are talking about. Statistics like 5.6 into 2 up to 24.3 cases per lakh women, they sound very, very distant. But this kind of hits you in the face. Every 7 minutes, one Indian woman dies of cervical cancer. So that is the magnitude of the problem. And in fact, India is the capital for cervical cancer. So now, like most of the infections are harmless, as I said. Most of the infections will go away. They are self-curing. But what happens, why do some women develop cancer of the cervix, which is an HPV infection? This is because they have other risk factors also besides HPV. So basically, it is the seed and the soil theory. The seed is HPV, and the soil is also prepared by smoking, parity by the number of children. Greater is the number of children, greater are the chances of CS cervix, contraceptive use, early coitus, many sexual partners, history of STDs, sexually transmitted diseases, and chronic immunosuppression, like as you have after renal transplant when the patient has to take in immunosuppressions for a long, long time. The symptomatology of cervical cancer, there would be recurrent UTI in this person. This lady would complain of recurrent UTI. She has an infection which stays on and on, keeps coming on and on. Pain in the lower abdomen, fullness in the lower abdomen, though this may be a late symptom. Pain in the lower abdomen, pain in the back, as I said, pain in the back and legs, which is also a late symptom. There may be a loss of weight and appetite, but the earliest of the symptoms is postcoital bleeding, which is bleeding after sex. Pain in the back and legs, I've already enumerated, and she might also have vague lower gastrointestinal symptoms. So this is largely the symptomatology of cancer of the cervix. This is a staging with the increase of the size of the tumor from 1A, where it is confined only to the cervix, 1B, and then stage 2A, where it goes into the perimetrium, not up to the pelvic wall. 3A, it spreads into the upper 1/3 of vagina and involves a part of the perimetrium. 3B, it extends right up to the wall of the perimetrium, up to the lateral pelvic wall. And stage 4, of course, is distant metastasis. 4B would be distant metastasis. Why is staging important? Because the survival depends upon what stage are we seeing the patient, what stage have we started treating her. So with stage 1, we can see hardly about 13% of all the patients of CS cervix would report in about stage 1, and the 5-year survival that we can offer them is about 83.5%. Stage 2 is about 34% of the women who come with CA cervix are in stage 4, and we can give them a 5-year survival of about 81%. Then comes stage 3, which is most frequently seen. So most of the patients come to us either in stage 2 or in stage 3, which account for about 80% of the cases. And the 5-year survival for stage 3 is 66%, which falls to 37% for stage 4. And the number reported in stage 4, percentage reported in stage 4 is about 7%. Now, cancer of the cervix. Are we looking into, do we want to treat for cure? Yes, of course, we do want to treat for cure. Every disease, yes, but why do you need to look for cure if you can prevent the cancer? I mean, cancer cervix, it is so amenable to screening, it is so amenable to early diagnosis that we really can concentrate all our efforts, or rather most of our efforts, towards early detection, screening, and catching the cases early. So this is what we are looking into in screening for cancer of the cervix. This is on the top left is the normal cervix. Then comes low-grade CIN, which would normally revert by itself. Then comes high-grade CIN, which will need very minimal treatment. And then comes frank squamous cell carcinoma of the cervix. The nomenclature, of course, has changed. We'll talk about that later. So how do you screen? You do a Pap smear. So a cervical smear test is a simple procedure which involves gentle scraping of some of the cells from the surface of the cervix, spread it on a slide, and then we see it under a microscope. And the cytopathologist is able to tell us whether it's a normal smear or it's an abnormal smear. If it is abnormal, to what extent? When should the Pap smear be done? Well, the best time to do a Pap smear is in the middle of the menstrual cycle of the woman. So from day 9 to day 21, from day 9 to day 20 should be the right time to do a Pap smear for these women, for any woman for that matter. And how do you report a Pap smear? So this is reported according to the Bethesda system, which was devised in 2001. It divides the Pap smear, the abnormalities, into 4 categories. The first one is atypical squamous cell carcinoma, which really does not lead to anything, except that the patient needs to be followed up more and more frequently. Then comes low-grade squamous intraepithelial lesion. Most of the time it is self-limiting and under observation. If you keep the patient, the lesion is most likely to go away as well. High-grade squamous intraepithelial lesion, well, needs more observation, may need intervention also, conization and things, right? But what is important and what we are looking for and we want to root out is squamous cell carcinoma of the cervix. So that is the stage where, we would be I would say, disturbed, run to a hospital and look for treatment. Now, what are the limitations of a Pap smear? Like any other investigation, this will also have its limitation. There is inadequate sampling done in about 8% of the patients, despite the best of intentions of the technician and everybody else. There is reporting that about 8% of the samples would be incomplete, inadequate rather. False negative reports are seen maybe up to 20 to 30% of the cases would have a false negative report. They may actually be positive, but they come out to be negative. They are reported to be negative. Infrastructure requirements. Well, you need a proper setup. You need a proper room, a gynae evaluation center. You need a gynecologist or at least a technician to be able to, a trained technician to be able to obtain the sample and to prepare the slides. You need an expert cytopathologist to interpret the slides. And then there might be socio-cultural issues involved. I mean, women will not go to a male nurse who would want to obtain a sample for a Pap smear. And in some societies, women may just not go to the hospital to get screening done unless they have a major issue with them. Women generally will not go to the hospital in some societies. What is the benefit of screening in cervical cancer? Well, it has been seen that 70% of reduction in cervical cancer deaths in societies which lend themselves to screening very well. It has been observed that 70% reduction in cervical cancer deaths. Cervical cancer, after the evaluation of HPV and after the screening techniques and all, now it ranks about 14 for cancer deaths in the developed world. For India, however, and for the developing world, in cancer deaths, I'm not very sure, but then for cancer incidence, in the rural areas, it is the number one malignancy in women, and in the urban areas, it comes only after CE of the breast. So it is still a major health issue for the underdeveloped countries, including India. Then 5-year survival rate, approximately, patients who come with screening after cervical screening and all, they would they would also be caught early. So the 5-year survival rate turns out to be a good 92% in these people. Screening recommendation. Who should be screened? At what age and at what frequency? Well, less than 21 years of age, you don't need to screen the girl. You don't need to screen the woman. 21 to 30 years of age, a Pap smear is recommended every 3 years. From 30 to 65 years, a Pap smear is recommended every 3 years, or a Pap smear plus HPV testing every 5 years. So you can do a Pap smear every 3 years, and after 65, you may do a Pap smear every 3 years, or if you want to do an HPV testing also, then you can repeat a Pap smear at 5 years, plus of course HPV testing every 5 years. More than 65 years, screening is not indicated for HPV. Pap smear is not indicated. Now, a word about HPV vaccines. Well, vaccines are made of virus-like particles, and they resemble the outer coat of the authentic virus. So, and in this case, there is no lipid membrane, so you get straight away DNA particles from this virus. What are the vaccines available? Cervarix, which is a bivalent vaccine. It is effective against HPV type 16 and 18. Gardasil, the quadrivalent type, which is available against 6, 11, 16, and 18. And Gardasil 9, which is a nonavalent type, 6, 11, 16, 18. Now, as I said, the most frequently involved virus type is HPV type 16, followed by 18, and then 6 and 11. So Gardasil 9 offers you a protection against all these strains, 6, 11, 16, 18, plus 5 others, 31, 33, 45, 52, and 58. Now, Cervarix, CERVAVAC. CERVAVAC is a new vaccine launched by the Serum Institute of India, and it is a quadrivalent vaccine effective against 6, 11, 16, and 18. So this is the first Indian vaccine against cancer of the cervix, which has been launched recently, and it will soon be available very well and at a very cost-effective price that we'll be able to get Cervarix, which is the Indian cervical cancer vaccine against HPV. Now, HPV prophylactic vaccines should all be delivered intramuscularly in the arm, specifically in the deltoid region, at a standard dose of 0.5 ml. So, कहाँ पे देना है, कैसे देना है, has all been clarified in this, that the dose is 0.5 ml and it should be given intramuscular in the deltoid region. So that takes care of the administration part of the vaccine. What is the time of vaccination. When should it be given? Well, ideally, before the start of sexual activity, and the ideal age is between 8 to 11 years before menarche. And the recommended ages are from 8 to 26 years of age. So a woman can be inoculated, can be vaccinated if she is anywhere between 8 to 26 years of age. Although before 26, she would have attained menarche long back. She would have most probably started on sexual activity also, but then it is still indicated from the ages of 8 to 26 years of age. The protection rate. Well, 100% of cancer cervix, as we saw earlier, is caused by HPV, and the vaccine prevents 100% infection. So ideally, it is 100% protection against the development of cancer of the cervix. But given between age 12 and 13, the protection rate offered is 87% against squamous cell carcinoma of the cervix. There has been an ongoing debate as to whether they need a booster dose after some time. Well, anti-HPV antibodies have been detected in the blood even after 10 years, and the titer of antibodies does not seem to be falling. So we would need more data and more observation if these people who have been vaccinated before the age of 26, would they need a booster dose at some point of time after some interval, after a few years maybe. That would, I think, await more observation and more, I think, data to come in, data to filter in. Now, specifically the Indian vaccine, with one dose, the efficacy of the vaccine is around 35%, which really is nothing to write home about. But then you add another one to it, and it goes up to 90% given above the age of 15 years. So below the age of 50 years, so given above the age of 50 years, this vaccine will, CERVAVAC, the Indian vaccine, will give a protection rate of about 90% to all the women. However, given below the age of 15 years, it gives you almost 100% protection. So that is the efficacy of the CERVAVAC, which is the Indian vaccine launched by the Serum Institute of India. Now, the number of injections. How many injections? Well, the earlier schedule was 3 doses in 6 months, given at 0, 1, and at 6 months. The new schedule which was given was girls and boys less than 9 years, between 9 to 14, 2 doses would suffice at 0 and at 6 months. However, given between 15 to 25 years of age, or rather 26 years of age, these people would require 3 doses at 0, 1, and 6 months. So which, going back to the initial schedule, if the latecomers take more, those who come under 15 can be spared 1 dose, which is a median dose at the time of 1 month. That dose can be spared in people who come on time. Now, WHO has come up with a recommendation in last year in December for cervical cancer vaccine in a bid to boost vaccination coverage. And it says that 1 dose schedule for girls ages 9 to 14 years adequately protects against human papillomavirus, and more specifically, the HPV 16 and HPV 18 strain. So this would be a huge boost to the immunization program of all the countries. It is going to be a huge savings for all these people, and especially for the underdeveloped world, is going to be a huge saving by way of infrastructure and by way of staff, by way of hospital facility and everything else. So Gardasil is also approved for men for anal cancers, women for anal cancers, and it should be given between the ages 9 to 26 years of age. Gardasil and these cervical cancer vaccines would also prevent, again, anal condylomata in both the sexes. In some countries, it has been also approved for oropharyngeal malignancies because oropharyngeal malignancies also have a large association or a significant association with HPV virus 16 and 18 again. So in some countries, especially in Australia, it is also approved for men for oral malignancies. So what is the extent of the use of the vaccine? About 82 countries have included this in their national immunization program. India, I don't think has, as of now, included in their national immunization program, but I think with the coming of CERVAVAC, this should also follow for us also. Adverse effects of the HPV vaccine seen in about 1% of the patients or more. There may be pain at the local site, there may be swelling, itching, bruising, bleeding, redness, or a hard lump where the shot was given. 0.5 ml giving rise to a hard lump. Well, it might be a small nodule. I won't call it a lump, but it might be a small nodule. And there might be the usual symptoms of a flu. There might be body ache, headache, nausea, fever, or there might be dizziness in these people for a short while. What is the cost of the vaccine? Well, Cervarix costs about rupees 2,000 for a shot. The cost may vary for either 2 injections, or if the patient takes it after the age of 15, then it will be 6,000. Gardasil was slightly more, it was about 2,400, but Gardasil 9, one shot costs around 9,000 rupees. So this is not the cost of the entire regime of 2 or 3 vaccines. This is a cost of a single shot of the vaccine. About the Indian vaccine, CERVAVAC, the cost is yet to be out, and we really don't know how much it will cost, but I'm sure it will be more cost effective than any of these vaccines which are available in the market as of now. So thank you very much, and keep safe and take care. Thank you.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one. I definitely think this session knowledge is going to help all the participant doctors on their practice. I can see, sir, we have received some question. If you allow, can I take this question with all your permission?
Yes, please do.
First question I can see from Dr. Agarwal. He is asking what is the link between genital HPV infections and cervical cancers?
Dr. Agarwal, 99.7% of cervical cancers are caused by genital HPV infections. That is the link. It is stronger than the link between smoking and lung cancer. So there's a huge association, there's a proven association, and this discovery of this association was such a landmark in medicine that the person, Dr. Sorry, I can't recall his name, he won the Nobel Prize for it.
Thank you so much, sir, for answering this question. I can see another question from Dr. Chauhan Ashok. He's asking why not vaccine sexually active men too?
Sorry?
The question is from Dr. Ashok Chauhan. He's asking why not vaccinating sexually active men too?
Yes, you are absolutely right, Dr. Chauhan. You are absolutely right. I mean, it should be recommended in gay men and bisexuals, and for oropharyngeal malignancies also. It should be ideally it should be for both the sexes, but then somehow I believe only Australia and I guess Canada is the only country, these two countries, poles apart, as you know, they have approved it for oropharyngeal malignancies also in both the sexes. Why isn't the Drug Controller General of India doing it? I really don't know, but I'm sure things are being moved and papers are being moved to get the clearances done.
Okay, thank you so much, sir. I hope that Dr. Chauhan has received your point of view, sir. Moving forward, I can see another question from Dr. Subramanian.
Yeah.
He is asking what is the role of leukocytes antigen, that is HLA, genes in the pathophysiology of cervical cancer?
I think that is an entirely new topic, another topic. So next time when we are anywhere close to that topic, we'll come to it as well, Dr. Subramaniam. Okay.
Okay, thank you so much, sir.
Let us
I can
also
see one
restrict
last
ourselves
question
to
from.
HPV. Yeah.
Yes, sir. Thank you so much, sir. And I request to join Dr. Subramaniam next session. We will discuss this question on that topic.
Yes, please.
Sir, let's move, sir. I can, yes, sir.
Sorry.
Sir, last question I can see, sir, from Dr. Kumar. He's asking, what is TNM system grading for regional lymph nodes in involvement in cervical cancer?
Yeah. See, TNM grading is always there for all the cancers. And, I have not elaborated over here, but I mean, if you want, I could read it out, but it takes about half a page to read out. But I believe if you go to the net and if you type TNM staging for cervical cancer, it is all there for you to see. Okay. So just do that. और उसके बाद भी अगर कोई problem हो, just call me and I'm sure we'll sort it out. Okay.
Okay, thank you so much, sir. I hope that Dr. Kumar has got your suggestion, sir. As I can see, sir, there is no more question from the participant end, but there is one feedback from Dr. Ankita. She has written very well discussion and good topic to be covered.
Thank you very much.
Okay, sir. And as there is no more question, sir, if you allow with all your permission, shall we conclude this session?
Yes, please do. Let's do it. Yeah.
Okay, thank you so much, sir, for once again sharing your valuable time here. I hope this session knowledge is going to help all the doctors on their practice knowledge also, sir. As there is no more
And just
questions, sir, we are closing here
just
and
one
hope to
thing.
see
Just
you
one
again.
thing.
Yes, sir.
What was that question about HLA?
Let me tell you, repeat this question once again.
Yeah.
The question is, what is the role of human leukocyte antigen HLA genes in the pathophysiology of cervical cancer?
HLA genes.
Exactly, sir.
Okay, fine. Okay. Yeah. ठीक है.
Okay, sir. Yeah, hope to see you again with different topic in coming times. Till then, take care of yourself. It was a wonderful to have you in our platform, IGCP, sir. Group. Thank you so much.
Thank you very much, and you too. Yeah. Bye-bye.
Welcome.